studying the ankle block, it is advisable to study anatomy of the nerves at the ankle as outlined in Chapter 7 of the Primer of Regional Anesthesia Anatomy. Ankle block is very widely practiced for distal foot surgery. It is probably the most commonly failed block of all peripheral nerve blocks for two main reasons. The fascia layers and the relative position of the 5 nerves to the fascia layers around the ankle are not widely understood, and not all 5 nerves are always blocked in ignorance or disregard of the fact that the areas of sensory nerve supply of the foot overlap, and this overlap is not consistent. The most common indication for ankle block is diabetic foot surgery. Practitioners should be cautious of A. The skin around the ankle of these patients is often very fragile, and ankle blocks often lead to skin necrosis. And B. These patients often have neuropathy that gives the anesthesiologist a false positive sense of his or her success with this block until he or she attempts an ankle block for bunion surgery or rheumatoid arthritis surgery on a patient with normal nerves. The other widely used indications for ankle block is thus for the management of postoperative pain following bunion surgery and also for surgery in rheumatoid arthritis. The ankle block can and should be used for most distal foot surgery, but is not suitable for ankle surgery. It can be painful to place an ankle block, and liberal use of skin infiltration with a fast-acting local anesthetic agent such as lidocaine, injected slowly and with a fine needle, is advised. There should be no problem placing an ankle block in a heavily sedated or anesthetized patient. Never add epinephrine to the anesthetic solution. From this diagram, it can be seen that the nerve supply of the bones of the foot originates from all the lumbar and most of the sacral roots. Selective nerve blocks around the ankle, therefore, almost always leads to some degree of failure. This diagram should convince anesthesiologists to block all 5 nerves around the ankle joint for every foot operation except maybe for the most superficial skin surgery. In these cases, local field blocks should be a better choice. It can also be seen that the dermatomal supply of the foot originates from a wide area in the lumbar and sacral spine, from L4 to S2 at least. The medial aspect of the foot receives its sensory supply from the saphenous nerve, which is a branch of the femoral nerve. The deep peroneal nerve supplies the area between the first and second toe, while most of the dorsal aspect of the foot gets its sensory nerve supply from the superficial peroneal nerve. The lateral aspect of the foot is supplied by the lateral dorsal cutaneous and lateral calcaneal branches of the sural nerve, which in turn originates from the tibial nerve in the popliteal fossa behind the knee. The medial and posterior aspect of the heel receives its sensory nerve supply from the medial calcaneal branch of the tibial nerve. From this image, it can be seen that there are 3 nerves that are superficial to the fascia, which is represented in a purple line in this image and is indicated by the arrows. These nerves are A. the superficial peroneal nerve, C. the saphenous, and E. the sural nerves. Note that the names of all 3 of these nerves start with the letter S. Deep to this fascia and between the tendons of the hallucis longus, I, and anterior tibial, H, muscles anterior, is the deep peroneal muscle in close proximity to the tibia, and posterior, adjacent to the tibial artery and vein in a complex array of fascia compartments, is the tibial nerve, G. The tibial nerve is a motor nerve, which makes its identification with a stimulating needle and a nerve stimulator relatively easy. Please remember that the local anesthetic agents do not cross fascia layers readily, and it is thus important to place the needle in the same fascial compartment as the nerve. The method described in many older textbooks of approaching the tibial nerve from posterior until the bone of the tibia is encountered and then withdrawing the needle slightly is outdated and possibly an important reason why many ankle blocks fail. Please keep in mind that the tibial nerve supplies approximately the complete sole of the foot. If a nerve stimulator is used to identify the tibial nerve at the ankle, 5 to 7 milliliters of 0.75% or 0.5% ropivacaine or 0.5% bupivacaine, can be injected on each of the 5 nerves. It is very important to remember that epinephrine addition to the local anesthetic agent is absolutely contraindicated when doing an ankle block, since this can seriously threaten the integrity of the blood supply to the foot. It can be seen on this image that the main blood supply to the foot, the dorsal pedal artery, and the posterior tibial artery are situated in close proximity to the tibial nerve G and the deep peroneal nerve B. With the patient in the supine position, the knee slightly flexed, and the foot externally rotated, the posterior tibial artery can usually be palpated behind the medial malleolus. The tibial nerve is just posterior to the artery. If the artery cannot be palpated, the surface landmark of the nerve is usually halfway between the medial malleolus and the Achilles tendon. The skin and subcutaneous tissue is infiltrated, with 1 to 2% lidocaine taking care not to penetrate the fascia with a fine needle at this stage. A 22-gauge, 2-inch stimulating needle attached to a nerve stimulator set at a current output of 1 to 2 milliamps, 2 Hz, and a pulse width of 200 to 300 microseconds is used to locate the nerve. Toe flexion indicates that the nerve has been encountered. The nerve stimulator is now turned down so that the brisk motor twitches of the toes can still be observed at a current output of 0.3 to 0.5 milliamps. This may not be possible in diabetic patients due to diabetic neuropathy, where much higher currents may be required. The motor response will immediately cease upon injection of local anesthetic agent. The foot is internally rotated, and the valley from the lateral malleolus to the Achilles tendon on the lateral side of the ankle is turned into a hill. Be sure to remain superficial to the fascia with the needle, and be sure that a skin wheel is observed when the sural nerve is blocked. This is a pure sensory nerve, and it does not matter if the skin infiltration contaminates the nerve, as is seen in this recording. The main dose of the local anesthetic agent is now injected subcutaneously and superficial to the fascia, again observing the skin wheel. Taking care to remain proximal to the retinaculum that approximately joins the medial and lateral malleoli, the tendons of the anterior tibial muscle and extensor of the big toe are palpated. Lidocaine is injected all the way down to the tibia bone between these 2 tendons. The same needle entry site is used, and the lateral subcutaneous area to the fibula is injected with lidocaine. The area around the saphenous vein is also anesthetized using the same needle entry point. A 25-gauge needle attached to a syringe with local anesthetic agent is inserted between the tendons of the anterior tibial muscle and the extensor hallucis longus until it encounters the tibia. It is then slightly withdrawn, and 3 to 7 milliliters of local anesthetic agent is injected. Without leaving the skin with the needle, it is now directed laterally between the skin and fascia layer towards the fibula. Note the skin wheel that is raised during injection, which indicates that the injection is subcutaneously yet superficial to the fascia. Intradermal injection, like injection deep to the fascia, will lead to failed block. Direct the needle medial and subcutaneously towards the anterior aspect of the medial malleolus and observe the skin wheel while injecting on the saphenous nerve subcutaneously and superficial to the fascia around the saphenous vein.